Emily Spinner, who made the technology work today. So thank you, Emily. Also, thanks to Amy Semrad, who's been a stalwart in making sure the CME activities go forward. We'll talk a little bit about that in a second. Carolyn, thank you for the kind introduction. Dave Liebers, if you're on, thank you also for your inputs and knowledge in infectious disease. So we're going to begin today, and I hope you can see this screen. The screen simply shows on the left a symbol or sort of an artist's conception of the coronavirus, showing the crown around the virus capsule itself, where the name comes from. In the middle, you can see some families in Siena, Italy, in the middle of their lockdown, having a little concert with their neighbors inside their homes, and two adorable Chinese children in Wuhan as the epidemic spread through their city. So let me just begin, and I'm trying to advance the slides, Emily. Trouble advancing my slides. Hang on one second. Okay, so there will be CME credits available, and those credits you can see here in your screen. I'll just take a second if you wanted to write down the websites for CME evaluation. That's so you critique me so we get better at this. And then if you want American Board of Internal Medicine information, there's another website. I'll just take a second for those of you who want to grab that to go ahead and grab that. Okay, so when you get on an aircraft, you know, they tell you where the aircraft is going. And in this instance, here's what we're going to talk about today. We're going to talk about some of the terms that you're hearing often about this disease, talk a little bit about the virus itself, very importantly about epidemiologic theory and how it is brought to bear on this particular disease. And then the progression, a little bit about the progression of this pandemic, and then some of the individual management topics and tools, prevention and mitigation, and then a shout out really to the New York State Department of Health, the Schenectady County Public Health Services, all of the teams at Ellis, community care physicians, public safety, and others who've cooperated so thoroughly with this activity so far. More to do, lots more to do, but thanks so far. This is just a housekeeping item, which is mandatory, and that's to say that I have no conflicts of interest here at all, and none of the people who helped organize this have conflicts either. And so to all of you who are currently on the front line of this very difficult and challenging epidemic, let me express to you my heartfelt thank you. This is very tough work. I also want to make sure that we recognize the incredible dedication of the workers, healthcare workers in Wuhan, Hubei province in China, and also the people who are currently working in Italy, France, and Spain, and they're in the middle of this. And of course, our neighbors in the state of Washington, who have been the leaders in much of this in the United States. So thanks to them. I'm going to now give you a pictorial tour of the march of this virus, and I'm going to take you to a website, and we'll watch together as the progress of this virus has taken place across the globe. Before I open the website, I want you to be aware that if you look in the upper middle of this, it'll give you the rolling dates of the movement of the virus. So kind of move your eye up and down as we open this up. So here we go. The red dots are places where there are 50 plus cases, and you can see the other dots. So now I'm going to run the animation. Keep your eye initially on China, then watch Iran and Europe, and then watch what happens when we get to the United States. So are you ready? Here we go. We begin in China, Wuhan, and gradually Thailand. You see others. Now this is the 21st of January, 23rd, 26th of January. Now we're at February 2nd. Italy's had its first cases. Now we're at the 9th of February. Cases in the United States and elsewhere. And now we begin to get huge spread in China, as you can see. And now Italy begins to be red. and Iran is now red. By the 3rd of March, you see state of Washington. And you can see France and Spain, and of course, more cases in Italy. And now we're at yesterday. So you can see the incredible spread in New York City, the deep, deep red there in New York City. So I thought this was interesting for all of us to look at. You can also see the big red dot down in the Sydney, Melbourne area in Australia. It is truly a pandemic. It is all over the entire globe. And this is an ambitious little virus, and we'll talk more about that in just a second. So we're going to move on and talk about the characteristics of the virus itself. So the coronavirus is a positive stranded RNA virus. And the name derives, as I said earlier, from the characteristic crown-like appearance of those receptors that sit on the top, the spicules that stand up. Most often this virus is seen in animals, but the viruses have made species jumps before, that is from an animal species into a human. And the examples there are SARS, which occurred earlier, about a decade ago, in the Middle Eastern respiratory syndrome, MERS, which occurred even more recently. And it appears from genomic studies that once again, we've had a species jump, this time probably from bats, although it's not 100% certain, but it probably is from bats. And as you know, there are those markets in China where there's lots of wild animals that are made available, so-called wet markets that are made available. So there's lots of possibilities for wild animal spread of a variety of viral types. The respiratory coronavirus probably spreads in a fashion similar to that of rhinoviruses and adenoviruses via direct contact with infected secretions or large droplets and then aerosols when those droplets dry out. But for sake of today's discussion, we should think of the most important mode of transmission. In point of fact, these droplets that are expelled when we sneeze. And here's a little image of what that looks like when we do sneeze. Wait a second here. You can see that when we sneeze, there are approximately 40,000 particles in a sneeze, and they move at about 80 miles an hour. So this is an explosion of moist particulates when we sneeze or have a vigorous cough. When we phonate, when we speak, there is moisture that comes off our vocal cord. So even when we're not coughing, we are putting out a little bit, a few moist particles on a regular basis. Okay, so this is the virion, the virus particle itself. This is a lovely artist's conception of this particle, and this came from The Economist on the 14th of March. A couple of things that are important here, probably one thing that's the most important thing here, and that is there is a lipid layer around the virion. And the reason that I wanted to draw your attention to that, remember that lipids in the presence of soap dissolve or fall apart. So that's why hand washing with soap and water and cleaning surfaces with soap and water or 70% alcohol or a variety of the other things is so important, is because we can disrupt the viral capsid and disrupt the virus itself. So that's important to remember. And those of you who've put a drop of soap in oily water and seen it disperse know how powerful soap can be in the presence of a lipid. So we're going to move on now to talk about the nature of viruses in general. So viruses are obligate, they must be inside cells. They're obligate cellular parasites. This one, the one we're talking about now, has a particular affinity for the respiratory cells, the epithelium on the respiratory tract, and a particular receptor on that tissue called ACE2, angiotensin converting enzyme -2. These are abundant in the throat and lungs of all of us. And the way viruses behave is they're hackers. They get into a cell, they overtake our own genetic machinery and make multiple copies of themselves, ultimately bursting either into the adjoining tissues or into the bloodstream or into the airway. All of those with very serious consequences. This is just an artist's conception of actually how the viruses replicate. And I'm not going to get into the weeds here, but you simply see on the left the SARS-CoV-2. That's the actual name of the virus itself. And COVID-19 is the name of the disease. So here's the virus, SARS-CoV-2, finding its way into one of our cells, respiratory epithelial cells, going on to replicate its RNA, replicate the capsid proteins and the lipid layer, only to find its way by bursting out of the cell into adjoining cells or into the bloodstream. So a very clever hacker that can live inside us. And this, by the way, is a similar mechanism to what we see in influenza, similar kind of process, making multiple copies, boom, bursting them either into the airway, into the bloodstream, into adjoining cells. So we have heard a lot about trying to detect this particular illness and this particular virus. So I want to talk a little bit about the tests. And there are a number of tests. The one that is being used right now most often in the United States and in state laboratories is a test that is called a reverse transcriptase polymerase chain reaction, PCR, or RT-PCR. Without going into details, because they are complex, suffice it to say, this RNA virus is put into a device that allows the virus to then get copied onto DNA, and then the DNA copies with an indicator fluorescent element is grown up, build up until the signal is strong enough for the detector to say unequivocally that this is the virus. The detector fluorescent element has exactly matching genetic material to the replicated DNA. So this is a highly sensitive and specific test. Unfortunately, this takes a while to do, and then it takes a while to turn it around. So to the great frustration of investigators and public health people, there are not sufficient numbers of tests, and the tests take longer than any of us would like. The Europeans have a similar kind of test that was developed in Germany. It is also very accurate. It does not require the step to replicate DNA. The Chinese Centers for Disease Control actually purchased an antibody test, a test that uses either blood, plasma, or serum into a little cassette, and then indicator lines show whether there is the presence of IgM or IgG against this virus. This test ultimately in Wuhan was used at the bedside, takes 15 minutes to run, and had a sensitivity of 88% and a specificity of 90%. Those are pretty good numbers. They're certainly good enough to provide assurance to clinicians in the middle of a huge outbreak. In addition, the availability of a test like this is going to be in the future very important. And the reason why an immunoglobulin detecting test like this will be important in the future is that it will allow us by surveys to actually get a measurement of the seroprevalence of this virus as it's moved through the world population. And that's very important because we need to know the number of people who have acquired immunity. We believe, although it's not 100% known, we believe that after an individual has become infected by this virus, we build a robust immunity and should not be reinfectable, if that's a word, or be able to be reinfected, certainly within a reasonable period of time, months perhaps. We don't necessarily know if we can confer lifelong immunity with infection by the wild virus, but we certainly do know for a limited time people will have robust immunity. That's going to be important as we talk about some of the other things with transmissibility of this virus as the slides go on. There's also a test coming that will use ELISA, which many of you are familiar with from HIV/AIDS. Now I'm going to shift to talk more about the terminology that is being used by epidemiologists and kind of where that takes us. So the first thing is obvious, an epidemic, which is just an unusually frequent occurrence of a known disease. And a pandemic is when the epidemic is all over the whole world. So far, pretty easy. The attack rate is used by epidemiologists to describe the proportion of the susceptible pool that are affected by the virus. And in this case, we believe that the entire human race is susceptible. We do not believe there's any memory immunity or immunity from or cross reactivity from other coronaviruses. We believe that everybody currently is susceptible. In models that have been done in Germany and elsewhere, the attack rates are being estimated to be between 30 and 50%. 30 and 50% means that between, let's say, 100 million and 150 million Americans might be affected by this virus. Those are very big numbers. And remember, we'll talk in a bit, that the bulk of the illness that occurs is actually quite mild, but these attack rate numbers are very high when the entire global population is naive or susceptible. The R naught, or reproductive number, is very important. I'm going to talk about why it's so important to know that. But the R naught really describes how many other individuals become ill after they contact someone who currently has the virus in their secretions or in their body. So the R naught, right now we believe the R naught for this virus is probably 2.3, 2.5, could be a little higher depending on which country we're talking about. But it's really important, and we're going to go on and talk about this in a bit as we show some examples of what R naught looks like in models. The case fatality rate, or CFR, is simply the number of deaths that occur over the total number of affected people. The case fatality rates have been estimated for general populations to be about 2%. In some instances, it might be a shade higher. In other instances, it might be a bit lower. But for sake of argument for today, let's think in terms of about 2% of the affected people will ultimately succumb. As many of you know, the senior populations in China and in Italy have been devastated by this once they become ill, and their rate of death is perhaps 5 or 6 times higher than the average rates of death for people affected by this virus. The epi curve is simply a plot of the number of cases on the vertical axis over the number of the days in time or months on the x-axis. And this is the curve that you hear talked about, flattening the curve. We're going to show some examples of epi curves, but this is a tool that epidemiologists use all the time when they're tracing disease through a period of time through a community. The incubation period, I think most of you know, it's the time from when an individual who's naive gets exposed to the virus to the time that they have the onset of illness. It looks like for COVID-19, it's between 2 and 14 days, on an average of roughly 5 days. And increasingly, we're beginning to understand that even in people with very mild disease have sufficient viral loads that they probably can affect and infect other people even when they feel asymptomatic or pretty well. Herd immunity is a really important concept, and this is the protection of a single individual by contacts in their environment who are immune. Let me give you a quick example, and this will ring some bells. If a child has an immunodeficiency and cannot be immunized with a live attenuated vaccine like measles, and goes into their classroom and all their classmates are immune, it is very hard for wild virus to enter that community and get at that child who isn't immunized, because they are protected by the herd, if you will, those around them who are immune. Herd immunity can be conferred in 2 important ways. One is by a powerful immunizing vaccine or agent, and the second is by individuals who've already had the disease and are now in convalescence or have immunity. So herd immunity can be conferred in those 2 important ways: immunization and convalescence from the disease itself. we're going to talk about something that is called the herd immunity threshold in a bit. That is the number of the percent, I should say, of the population that needs to be protected to have the transmission of virus stop. And the transmission of viruses stop when their reproductive number drops below 1. So it must get below 1 for the movement of the virus through a population to cease. We'll talk about that in terms of herd immunity in a bit. An index case is that first individual who's affected. When we go back and look at the Wuhan data, it appears that probably the very first person affected by this was sometime in December 1919, probably around the 10th or the 12th. Cases began to pour into the hospital by the 31st of December, and then it was off to the races in January and February. Quarantine, I think you all know, it's simply the restriction of individuals and isolating them by physical measures, keeping them in a confined space. And the actual name, as I said earlier, of this virus is SARS-CoV-2. It's that virus that is causing this particular disease. So that's a lot of vocabulary, and to some extent I apologize, but I think as we go forward, you'll see why it's important to have this vocabulary for all of us to use and understand. Now, this is simply a chart that shows on the horizontal axis the average number of people infected by each sick person, which remember we defined as R0, or the reproductive rate. On the y-axis, or the vertical axis, it looks at the case fatality rate, which we abbreviated CFR. So I wanted to show this chart to show you that COVID-19 occupies that dotted box down there with an estimated transmission, or R0, of between 1.5 and 3.5. Remember, we said it was around 2, which is kind of in the middle of that range, and a case fatality rate of between 0.7, which is probably on the low side, and 3.5, which may be a shade high. So just as you look at that box, you can see that far more dangerous and severe are things like MERS, way up higher, Ebola virus, and also polio, and certainly smallpox that had a case fatality rate of about 25%. And then if you look at the R0, you see it's kind of in that sweet space, not too far beyond influenza, but definitely beyond influenza, but not nearly as far out as measles. We believe that measles, under certain circumstances, has an R0 of 10 to 15 and maybe even 20. That means that one child who develops measles in the presence of naive individuals could infect as many as 10 to 20 other children. So summarize, it appears to be that this COVID disease, this virus that carries COVID disease, is twice as infectious as seasonal influenza, and probably as much as 10 times more deadly, somewhat under 1% for seasonal flu and up around 2% for this particular illness. So once again, Dr. Fauci, Tony Fauci, maybe all of you have seen on TV, made this point. The disease is twice as infectious, but 10 times more lethal and more deadly than the seasonal influenza. So on we go. This is simply a look at the case fatality rates for seasonal flu versus COVID-19. And not too surprising, because we've already talked about some of this, but more importantly, if you look on the right-hand portion of this chart, you see how high the rate is for those who are 60 years old and older, between 6 and perhaps 8 times more serious, more lethal. These are the epicurves that I talked about, and these are just examples of epicurves. I wanted you to note something very important, and this is every time you see an epicurve, you'll notice it looks like a Gaussian distribution. It goes up and it goes down. And the real joy, I'm just going to go back here, the real joy is that all epicurves decline. And I'll show you some from Wuhan that show this very convincingly. There's a lot of information in epicurves, And in this lower one of a measles outbreak, you can see that the index case is here, and then the purple occurrence of other cases comes to the right of that. The distance between the index case and the onset of illness in the community is, in fact, the incubation period, here about 12 days. So there's lots of information in the epicurves and a lot we can learn by plotting the epicurve if, for instance, we know the index case. This is simply a chart that gives you a graphic of the R0 or reproductive number. Here, I'm sorry, let me go back here, forward. Here is the index case, they call patient 0, affecting 2 individuals who then infect 2 individuals. This is Ebola, and this is an R0 of about 2. And so we're slightly higher than this in COVID-19. Less than SARS, thank heaven, but certainly a little bit higher than Ebola. The important thing to realize is that if we get to in order to understand the herd immunity threshold, and hang on here, there's a little bit of math. The way we calculate that is we divide the R0 into the number 1 and subtract that from 1. So 1 minus 1 over the R0 gives you what we call the herd immunity threshold. And when I do that calculation for this particular virus, it's around 44%, which means in order for this to not get to hitting these other 2, you would have to have 40% of the entire population, slightly higher, 44% of the entire population immune, either from having had the disease or from vaccine. And as you know, we have no vaccine currently available. So the reason this is important is because we would then know how many naive people remain in the population if we could measure antibodies in a large sample of the population. So again, herd immunity threshold for this is about 44%. So we'd have to have 44% of the population convalescent in this case in order for us to be able to stop the forward progress of this virus. This was a gamble in the beginning that Great Britain tried to take. They were prepared to take the cases in order to let those who get it develop immunity and stop the virus spread. But I've just said it would require that 44% roughly of the population become ill with very serious consequences in terms of clinical illness. So if this is not clear, when the questions come at the end, I'll try to go over that, reiterate it again. But I hope you understand this idea of herd threshold immunity, 1 minus 1 over R0, and this whole idea of infectivity, 1 to 2 to so forth. This rate of infectivity means that there'll be a doubling time of cases in naive populations every 7 to 10 days, which is exactly what we saw in northern Italy and probably what we're going to see in New York City. Containment, you've heard a lot talked about, is stopping the spread of the disease at the beginning. Unfortunately, containment was not successful in the US. Containment was more successful in Hubei province outside of Wuhan. Draconian measures, as you know, were employed to do that. But we're really now in the US in the mitigation phase, where what we're trying to do is blunt the impact of this illness by using social distancing and the other measures that we'll talk about in a bit. I wanted to just one more time go over the immunity threshold here. I put the equation up for you to look at again. By the way, during the time of H1N1, when I was was privileged to work for Schenectady County Public Health, we calculated the herd immunity threshold. And we found that we had enough naive so that if we had a second wave of that disease, the illness could get a foothold in our community. So we then encourage people to continue to become immunized even into the spring of the year of the H1N1 illness and outbreak. Here you see I've calculated the number of people that need to be immune to stop transmission of seasonal flu, 33%, but measles, look at this. You'd need 90% of the population of, for instance, school children to be immunized to stop the transmission of measles. And you remember that on the West Coast, there are a lot of families that decided not to immunize their children. Herd immunity collapsed and transmission occurred in schools throughout California and Oregon. So this concept of the immunity threshold, conferring herd immunity, is really characterized by that equation. So flattening the curve. What are the interventions that can allow us to get toward mitigation? Certainly quarantine, we've heard a lot about that, from cruise ships to people coming off aircraft from places infected regions. The use of vaccines, sadly, we don't have a vaccine now. Vaccine development is not easy. And as Dr. Fauci said, we're at least 18 months away from really having an efficacious, believable vaccine for this illness. There's an RNA vaccine. Some of you have heard at Kaiser in the state of Washington is in a phase 1 field trial. A handful of individuals have had the vaccine, pardon me, in order to make sure that it's not going to be damaging or cause problems. Social distancing, this 2-meter distance has to do with the fact that there are droplet nuclei and certainly we're putting out moist particles, both aerosols and droplet nuclei, and 2 meters should be enough for most of those particles to drop out of the air onto the ground and not get into your mucous membranes. Hand washing we talked about because of the ability of soap to really blast that capsid of the virus, and then sanitizing with a variety of preparations containing alcohol and other things. Deep cleaning, we've heard a lot about that, to get residual virus, residual virus off surfaces. And you've probably heard that this particular virus in laboratory conditions can live for a day or two on surfaces including stainless steel and plastic. I remind people that when you do it in a laboratory setting, it is very different than what is happening in your kitchen or in a clinic. We know that viruses do not like to try to exist on a surface because they need living cells to replicate. They tend to die very quickly in the presence of ultraviolet light. And so if daylight streams in your kitchen and it's on your counter, it's not likely to last the kind of 4 days, 3 days. In our sputum and in coughing, probably a couple of hours, the virus can exist in droplets in the air that are moist. Covering coughs are important, and the drop in susceptibles that we talked about, the herd immunity or immunity threshold, is another way to mitigate this. So in order to drop the curve, and here we see flattening the curve, we need all of these measures, and we need to do them vigorously, as the Chinese did in Wuhan, and the Italians, unfortunately, got behind the 8 ball and weren't able to get this done as quickly. Probably the area under the curve is even a little smaller if we flatten that curve, but it may be that we just are pushing some of the cases further out in time. But anyway, these are the elements: quarantine, use of vaccine when it's available, social distancing, hand washing, deep cleaning surfaces, keyboards, doorknobs, whatever, covering coughs, and making sure that the convalescent people, they're going to help us. The convalescents will help us. Okay, so this simply shows what the outbreak was like in Wuhan. I don't want to belabor this. I think many of you have heard this. I do want to look at the case counts, and this is not an error. As many as 3,800 patients were being presented to their emergency rooms in the city of Wuhan. Now, this is, I think, 8 or 9 million people in the city of Wuhan, but this is an explosive outbreak. It begins with a relatively handful of number of cases presenting to the EDs in the hundreds, quickly getting to 3,200. So things can move on very quickly with this disease. Now, we talked a little bit about the attack rates, and these two figures simply translate that. We think that probably 30 to 40% will be affected. Of those affected, 82% roughly are going to have mild disease. 16% will probably have something like 16% will have serious illness. Maybe 5% will be admitted to the intensive care unit, and perhaps 2%, as we said, the case fatality rates of 2% will unfortunately perish with this disease. So the clinical presentation in Wuhan for this disease we'll outline here. The bulk of the people who were ill had fever. We now know that you can have a mild episode of COVID-19 and have a very low-grade fever. You certainly can have cough. Now we believe you can have a coryza-like picture with a runny nose and certainly fatigue. And then ultimately sputum production. And when the illness really takes hold, a lower respiratory tract viral infection occurs associated with all those kinds of feelings in the chest, including shortness of breath, rapid breathing, low blood oxygen, respiratory failure, heading into things like shock, multi-organ failure, and then unfortunately in many cases for people who develop multi-organ failure, they have an unsuccessful outcome and succumb to the disease. This is just to show you that individuals, we've heard recently from the CDC and from the White House that that people who are partying on the beaches currently at Fort Lauderdale and other places in Florida are not immune or will not be skipped over by this virus. They pointed out that 40% of admissions to some of the facilities in the United States were in this age group. Well, this is Wuhan data. And you can see that if you look at the bracket inside, those are people from 20 to about age 60. And you can see more than 40% certainly fall into that age group. And some of them, in fact, do succumb. The older succumb more often than the younger. But we see in China and Wuhan, we certainly saw people in what I call the prime of life years from 20 to 60 affected and ill and with some mortality. We've already talked about this, so we won't go into the left-hand side. The right-hand side showed the comorbidities that were most often associated with fatalities, including cardiovascular disease, diabetes, and chronic COPD or chronic respiratory disease, as well as hypertension. So a major question that epidemiologists are struggling with is why aren't little kids like these, toddlers and first and second graders, why are they not affected? I mean, in China, very, very few. So far in the US, very, very few. And we don't know the answer to this, but it's a haunting question and probably has information for us to learn about the way we approach this illness. It may be that the immune systems of these children is more robust than those of us who have waning immune systems as we grow older, or maybe that these children are seeing other members of the coronavirus family on a regular basis and have some cross immunity. If that is the case, that would be a very interesting thing to understand. I'm going to just show some radiographs of what it looks like when these people have serious disease. This is a 61-year-old man, Chinese gentleman, who ultimately succumbed to his disease. You can see a progression over 3 days of a dense kind of pneumonia, ultimately developing fluid around the lungs and quintilobe, or every lobe of the lung involved with this. He did not survive. In Wuhan, some of these patients were put on ECMO with plus minus results. These are just some CT scans, and this pattern here that you see, so-called crazy paving. Let me just go back to that. Crazy paving was seen in a lot of these cases. These are a number of individual patients, but my looking at the x-rays from Wuhan, I was not as impressed by the plain radiographs, but when the Chinese did a few slices of the CT, this disease, this abundant disease here with infiltration of the alveolar spaces, and the septi was more obvious. So some caveats about the clinical presentation. The plain radiographs at the beginning may be unimpressive, progressing to very serious things. Perhaps 5% of the cases will need hospitalization for hypoxemia or for other problems with the disease. 2% of them may need ICU beds and 1% ventilators. This is a vigorous immune response, cytokine storm, so-called. All these elements, D-dimer, IL-6, and procalcitonin levels in the seriously ill patients were way up. Platelet counts fell. which portended a poor prognosis, and then ARDS and multi-organ failure, certainly are grave indicators. And we've already said that survival in the elderly is very poor. This is just a comparative slide quickly between people who died and people who survived. And what's important here, I think, is that, again, the age-shifted populations, and in the lower left panel, showing you that there's an actual overlap between those who died and those who survived. So although those who died certainly had higher C-reactive proteins and free myoglobin, and also troponin suggesting heart injury were higher, there was overlap in almost all of these indicators. We know the Chinese did measure troponin in a number of these cases and found that either the heart was directly damaged or by the virus, or damaged because of hypoxemia or other things. We don't really know, but we know the heart is a victim in some of this as well. So what can we do to impact this? We've talked about social distancing, trying to keep 2 meters, 6 feet apart because of the way the droplets will fall out of the air. We've talked about remaining calm in the face of building anxiety. Those of us who are health professionals really need to make sure that when people ask us about this, we tell them that we understand this disease. We know that around the world, people using appropriate precautions can treat these patients. We learned that with Ebola. We learned that with SARS and MERS. You can treat these people if you wear precautions and are not infected yourself. Hand washing and sanitizing, covering coughs. If sick, we need to make sure we put a mask on patients immediately, certainly limiting travel, cruises especially, and probably aircraft as well because of circulating air. I think this has been a tremendous blow to the cruise industry, which was already in trouble because of norovirus outbreaks, but this is certainly not going to help that industry. Cleaning, we talked about soap, 70% alcohol, bleach solutions, and other EPA approved cleaners. And you can go to any of the websites, CDC or other, and you can get a list of ways you can make these at home, or what they might look like. So if you've run out of things like commercially available, you can make some of these materials yourself at home. And so guidelines for laboratory testing right now, as you know, the test kits are very scarce, currently being held for clinically ill patients at both and all the hospitals in the capital region. Environmental disinfection, of course, in our acute care settings will go forward, and general waste regulations apply. The personal protective equipment that will be used is going to change with availability and with what we learn about this, but certainly we want to protect mucous membranes, protect our skin, protect our airways, and make sure the patient has a mask as well. These, again, as we said, depending upon the availability of variety of PPE, personal protective equipment, are going to change and move over time. So stay tuned on that as well. So is there a light on the horizon? Well, first thing we said is that all epidemics go away. And we know that also there are 2 or 3 or maybe 4 drugs that are being talked about. Remdesivir, which you heard some about, I think perhaps yesterday on TV, is a DNA analog kind of vaccine that was developed for Ebola, and it has been tried both in China and in the state of Washington. Too soon to tell on remdesivir, but looks interesting. This is a list of other agents. You heard a lot yesterday about hydroxychloroquine, which is used both for malarial prophylaxis and in malaria as well as rheumatoid arthritis. That's probably going to get a rapid approval by the FDA. Certainly would probably make sense in vitro, that is in laboratory. We know that this particular drug is both cheap and efficacious in killing the virus in vitro, that is in the laboratory. We talked here, if you look in the middle of remdesivir, it's the nucleotide analog. It is being tested. There's a large field trial going on right now in Wuhan results should be available in about 3 weeks, initial results. And in Italy, we have seen tocilizumab, which is a monoclonal antibody that's used in rheumatoid arthritis, is also was used again by the Italians. We'll have data from Italy on that probably in another month. So that's some light at the end of the tunnel. I show this picture. This is Xi Jinping, the president of China, the chairman of the Communist Party. And this is a photograph taken in Wuhan. So I don't think that the public health officials and health professionals in Wuhan would allow the president of China to go to Wuhan if they knew they were not at the descending, at the tapered end of the epidemic curve. So this disease does come and go, and you should have confidence that it will. So just a couple of FAQs and we'll get to your questions. It's about 10 minutes left in the hour. So one question that comes up again and again, and we talked about this a little bit early in the hour: if I recover from COVID-19, can I get it again? And the answer is not really known, but again, using the model of what we know of most viral infections, the likelihood is that we will develop robust immunity, at least for a limited period of time. It's not like some other kind of viral illnesses where we get robust and lifelong immunity necessarily, but we certainly will get some immunity. And this, in fact, will play a role in getting to that herd immunity threshold. Second question is, can the virus survive on fabric and surfaces? And some of you have heard that there was a published paper in one of the, in the New England Journal of Medicine, and also one of the microbiology journals, showing that it can last on laboratory counters. Stainless steel and plastic can last on fabric, clothing and cardboard, some to a fairly lengthy degree, which means that under laboratory circumstances, it can live for days, which means cleaning, deep cleaning and surface cleaning is important. Remember that ultraviolet light kills these viruses, and that soap and water is pretty powerful stuff as well. So I think we shouldn't trivialize the continued ability of viruses that are resting on a surface to infect you, but it's not the preferred mode of transportation and transmission for this virus. Remember, the virus, if you will, wants to be inside living cells. That's where it can flourish, that's where it can replicate, and that's where it can cause the most damage. Okay. And so I want to close with two things here. This is an interesting little comment from a ED physician in Alberta. Let's meet this challenge together in the best spirit of compassion for others, patience, and above all, an unfailing effort to seek truth, facts, and knowledge as opposed to conjecture, speculation, and catastrophizing, whatever that is. I'm thinking about catastrophes, obviously. Facts and not fear, clean hands, and open hearts. I'm going to just finish with a reminder too, please, to provide us with, one comment I want to make before I close, and that is, for those of you who are frontline health workers, adequate sleep, good enough nutrition, or more than good enough nutrition, and some exercise and fresh air is vitally important for you to be able to do your job. So self-care, taking care of you, is taking care of us. So please do take care of yourself so that we can take care of each other in this very important effort. Please. Here again, CME information and the registration forms for the ABIM are available at these websites. So with that, with about 8 minutes to go in the hour, I'm going to conclude. And so that's the end of